Hello.
Hello, Luigi. How are you doing?
Very, very good. Thank you so much again, psychologist Alejandro Ibarra, for meeting with us in the Ibarra Exchange all the way from Spain, Seville, here in New York. As people know, luigi.ibarra. I'm a PhD trained neuroscientist, and it's a pleasure to keep having these meetings every Sunday that we're going to have them for the rest of the year to talk about obsessive compulsive anxiety disorder and about the impact in people's life. How did your week go?
Thank you, Luigi, for having me here again. And we are in the third week of Ibarra Exchange, and the topic that we are talking about is OCD in gender, the difference between gender in men's or females, and that is the topic for today.
I was reading something this morning about not OCD, but COVID-19, that the phrase was a little bit like, this disease doesn't respect, as in it doesn't differentiate, doesn't discriminate, okay? But this disease doesn't respect gender, race, ethnicity, sexual orientation, and age, cultural background. That's COVID. Do OCD is just as disrespectful as COVID?
That's a really good question, because I think there is no difference between race, between ethnically, between age, between subtypes in OCD. OCD is a really disorder that impact in the whole life of the people that suffer this. So it's very, very aggressive in symptoms. The person or the sufferer that has these symptoms with obsession, with compulsions, and with high level of anxiety, they look their lives very impact. And there is no difference. There is no difference between age, and there's no difference between symptoms in themes or in subtypes. There is no difference between OCD contamination or hard OCD or ROCD or HOCD or magical thinking. Okay, so I think that we need some a new research to have some data or some concluent data about this, because in my practice office we see every day a lot of clients, a lot of patients with some difference, but no difference between gender. There is a equal between male or female. The difference are in the impacts in their life or in the age, but not exactly in the gender. Okay, that is a important point, because it's different, for example, with depression, that suffer more women than men, or another kind of disorder of anxiety, or GAD, for example, or panic attack. Okay, in OCD, no. The OCD is unique, is very particular disorder, and I think there is no difference.
And extremely severe. So unlike general anxiety disorder, GAD, and unlike other panic disorders, mood disorders like depression, bipolar, and schizophrenia, and psychotic disorders that is more likely in men. I specialize in traumatic brain injury and spinal cord injury. There are even they have injuries, but it's 2/3 each disorder on men and women, because of the reckless behaviors and these, pro do everything, not take care of yourself that much, that men have over women. They're also most likely to get into a fight in a bar once when the bars were used to open, or a car accident, or getting an injury in playing football. So it's amazing to me that just like the pandemic, OCD is this worldwide disorder that, impacts people's. And we were speaking before that in in the Spanish version that, okay, there is no conclusive research on almost anything, but even worse with OCD, there's not like a conclusive, at least, path where you can take. Like I was, reviewing the neuroscience of OCD, and there's studies that can go to the thalamus and the motor pathways of the basal ganglia, the striatum, that happens in Parkinson's disease. And there's others that specifically say, look, it's not related with only the cortex or the subcortex, but more of an integration of different parts of the brain. So I guess my question was, like, did you see at least any difference in genders in terms of the treatment and how they respond to the treatment and how they recover? Do men recover better? Do women do?
Yes, that's a good question. In the version, the Spanish version, we were talking about the difference between gender in male or females about the treatment. We have to remember that the gold standard treatment to OCD, for OCD, is the CBT, and particularly ERP, exposure with response prevention. So
in CBT, cognitive behavioral therapy.
Exactly. So in ERP, we develop some strategies or tools or skills to get into the correct path or correct way to the sufferer, to the treatment and the recovery. So it's not depends on the gender, depends on the motivation, depends on the implication, depends on the people has to the motivation to start the path to the recovery and walk all the path until the last session. Some people ask me all the time, what is the secret to the recovery? There is no secret to recovery. There is no secret. Exactly. There is no secret. There is a path that you have to walk every day. You have to do ERP every day. You have to face your fears. You have to control your compulsions. You have to manage your anxiety. And after that, every day you are getting better. You are do something with your brain and with your mind that is like muscles, like go to the gym, or train your brain like new muscles, and all of that process is going to help you to recovery, to the last session. And there is no secret, and I think it's motivation. But again, there is no difference between male or female. There are strategies or some skills or some tools that we get or we put into the person, into the people.
You brought excellent point. Let me switch ears a little bit and maybe play a little bit tough cop, bad cop here, and maybe not the time because of what's happening. It is true, okay, that in the United States, and we're not just saying women in OBGYN or men with urologists or, well, there's not like men's doctor, but there is data that suggests that, yes, people want to see doctors of their same gender or the opposite gender. And now you're talking about OCD. OCD is not only extremely negative, impactful in people's life, extremely impairment, but the treatment is not vitamin C, take Advil, be the treatment. It's not impossible. People go through it, but it requires a level, like you said, of motivation, of wanting to get better and putting work into it. At some point, the motivation, it's stop wasting 5-6 hours a day counting or with the rituals, and so I would guess the disorder is enough, the motivation to wanting to get better. But that therapy that you specialize, that specific cognitive behavioral therapy, and with the exposure prevention response, it requires a level of trust. It requires a level of, I know my clinician, my psychologist is with me, I need to be able to trust to carry me through. And there's got to be, you know, in the balance of the relationship, some sort of personality of, you know, one is the director, one of there is the actor, the executor. It's not so much as a simple psychologist-patient relationship. It's a little bit more.
Absolutely, absolutely. It's not easy to find a right therapist in all the world, and that is one of the big problems in OCD treatment and ERP, because definitely not all the psychologists are prepared or have been studying to treat the OCD. So respect your point of view about the difference. Definitely the ERP is hard, and the people has to work to get in through the recovery and into to work every day. And it's not easy. It's not easy. And people, when we receive the emails on many calls every day, people definitely want to solve the problem, want to find the right therapist, want to find the right path to the recovery, and want to find the experience in the therapist to help to the recovery. And that is the very important, because definitely it's not depends on the gender, depends on the abilities, depends on obviously on in the studies, the experience, treating OCD patients and clients every day through worldwide. So when patients or when clients call to us, to my practice office, definitely they want to solve the problem. They want to recovery. I call to psychologist Alejandro Ibarra to start my treatment to solve my problem or to recovery. I don't want to continue suffering. I want to study. I want to work. I want to have a partner or whatever. And that is the point.
Tell me a little bit more about your experience. Have you had better results with men and women throughout the years? You mentioned in your private practice there are other psychologists that work with them. What is their gender? Do you match when people come? Do you match men to women, women to women, men to men, patient? Do you see any sense of, like, you know, just anecdotally, that some women respond better to the women clinicians, and maybe in your own experience, if your male patients have responded better to the treatment?
I have a team, a psychologist team, to 8 psychologists. All of them are women, okay? So I try to put the right therapist to the profile of the client. Depends on the age, depends on the subtypes, depends on the evolution of the disorder, but not depends on the gender. Because to me, it's not a difference between men or female. The difference is between the abilities, the strategies, the experience, and how in Alejandroibarra we know deeply the disorder and how we can solve the problem to many people. That is the really big and good point. Not depends on the gender, depends on the profile between the psychologist and the patient.
So how about for telehealth? How about someone from New York, from the United States, from anywhere in the world that is watching this video and they want to contact and they want to be able to treat their OCD in English or in Spanish through telemedicine, telehealth, through these meetings? Would that person, if appropriate, you will be overseeing their treatment, or based on the characteristics of the psychologists that work for you or under you in your private practice, would you match based on with one of them, based on their symptoms, based on their stories, and based on the strategies? Because I assume it's a little bit like, okay, the new psychologists get to treat, you know, patients that are not that severe, and someone like you with more experience gets to treat the ones that are more.
Absolutely, definitely the telehealth and teletherapy is changing the world. In IOCDF, in the International Obsessive Compulsive Foundation, there is many studies from 2006 to 2018, and also last year we had many studies about telehealth and how ERP has improved the lives in all people through the world. So today is not a barrier. Today is not a today is not a big problem. The problem is that you said the match. It's not a problem. It's the point to match the right therapist, and not depends on the gender, to the profile of the client. For example, we are in Seville, and a client and sufferer is in New York. So my part of my job is to match and the profile, the right profile to my psychologist to the sufferer. Depends or between the age, the race, for example, and the subtypes. The subtypes is very, very important, because part of my team is more or know deeply some of the subtypes. Part of my team works with ritual or mental compulsions, and other of them work with motor compulsion. So it depends on the profile to the clients and the psychology. That is the point.
Let me rephrase something that we spoke on the Spanish section. Here in America, and not everyone, but there's a way of differentiating, people that went to college and those that not. When they talk about white collar jobs, they refer to people that do professions with university degrees, from medical doctor to lawyer to architect, engineers. When they say blue collar jobs, okay, they refer to people that work, the working class, that are doing work that didn't require a university degree, mostly in factories, mostly the jobs that you kind of like see people day-to-day basis. And there's no discrimination at all. I just want to understand something that you mentioned before, that OCD might have some sort of connection based on the socioeconomic status of the person. Could you elaborate a little bit more on that?
To my experience in my practice office, we see more symptoms with people suffering with OCD in medical doctors or lawyer or engineer than person or people with low level sociocultural. But it's not a big difference. I think that is depends on the personality, of the susceptibility of the personality, because some of the medical doctors or nurses or engineer has many OCD-P. That is not OCD disorder, okay? It's personality. So we see, and we have been looking this in our practice office.
When you say peaks, you mean features? You mean characteristics of their personality that are, because of their job, that make them a little bit more vulnerable to have OCD? Not from the neuroscience perspective, not from the biochemistry perspective. This has not been proven in the studies with the animal model, whether it's in mice, when you mimic the disease to study the genetics, whether you do it in rats, where they mimic the actual gestures that rats do to try to get an experiment with a specific treatment. We're more similar to rats than men are to women. But this is just, you're saying that because of their characteristics and because of their lifestyle and their everyday, maybe they're more vulnerable on the environmental to have this disorder. But isn't that extremely dangerous? Because you mentioned professions that I wouldn't want to have a nurse with OCD. suffering in that moment. I wouldn't want to have a medical doctor that is, you know, taking 30 minutes to make sure the right prescription of an asthma inhaler goes through. That could be, then I don't want to alarm the public, but that is something, you know, to take into consideration, that could be dangerous if you put in the health profession.
Not exactly dangerous. It's more the time that the people waste in the rituals, because we have some nurses or medical doctors that OCD contamination with blood, with the trigger with blood. So if they look or see a little blood, they have to, for example, wash their hands 20 or 30 times in that moment. So it's not dangerous, but the person wastes time. And it's very dramatic, because waste time, need more time to do the rituals, do the compulsions. People maybe also going
and to be fair, you don't even need to see blood to actually get go and wash your hands. We're talking right now that if, you know, after this pandemic, and we mentioned it before, that this washing your hands 20, 30 times a day, it is the must do. But for people that had OCD before, or, you know, the society consider them as germaphobes, or maybe to control, but it's not like they're washing their hands the same 30 times. Maybe they're watching it now 100 times. Everything gets amplified by it.
Time for a time, or 80 times, or 100 times. So people suffer with this disorder, because waste time and going to their work, for example, very late. Okay, very late, because the time that the ritual spend is every day and many times a day. So it's a big problem, but it's not dangerous. It's very devastating disorder. That is the right
let me ask you one last question, and it's going to be a great connection to our next week, when we're going to talk about OCD in teenagers. That there's not that much of it, but there are some hot recent studies that we're gonna discuss OCD in teenagers. Also looking at the parents, because that's sort of like you have 3 patients for every child. But at the beginning, you said OCD doesn't discriminate across the lifespan. Okay, so can someone has, I mean, it's very unlikely because of the plasticity, or actually no, because of the lack of plasticity. Can someone develop in the older age, when they're old, like after 60, OCD, not having it any previous time in their lifetime? Like you can develop the symptoms and the condition for your first time very late, just like they suffer very, like adolescents, very early in life.
We have in our practice office some medical doctors with 65 or 70 years old. So their symptoms doesn't start with 65 years old. Their symptoms start maybe at 12 or 13 or 16 years old. What happened? That the symptoms disappear many years, 20 years or 30 years with no symptoms. But the personality is obsessive. So these symptoms can appear after that time, maybe 30 years after that time. So
they might have features of OCD personality disorder, and then.
So we have in our practice office right now some medical doctors with that age, with 65, and medical doctors that are retired with symptoms with OCD with 65 and 70 years old. That is a reality, because OCD symptoms don't respect age, don't respect race, no age, no race, no gender, no anything. The condition and the symptoms.
It's like a virus. It can appear just like that.
Appear on conception after a trigger, and after that appears some intrusive thoughts. So anxiety levels and the people has to do a ritual, mental or motors. That is
when you say the trigger, and so maybe the person, you know, suffering a death in the family, a big stress, a big change in their life. I'm just thinking that medical doctor must have been very stressful to retire. Retirement really affects more people psychologically than we think. But because of that, it's almost like everyone has a sort of, you know, OCD features, and then there's a threshold, and then something dramatic happens. You hit the threshold, and then the rituals, the compulsions, the disruptive thoughts happen.
Yes, but not exactly a traumatic event, because OCD is the only one disorder that doesn't appear with after a traumatic event. Depends on multifactorial cause. So the triggers are everywhere. Trigger maybe could be a window or a door or an oven or a freezer or just
blood
or thinking about my orientation sexual, or my what if I don't love my wife or my husband. Triggers are everywhere, and triggers are whatever. After the trigger appears the rumination, or appears the obsessions, and after that appears the compulsion, and then after that you have OCD. That is very fast. It's like a cancer. It's like a cancer, but
very progressive the way.
Exactly.
It's not like dementia where there are differences in gender, but it's not like dementia where the deterioration, the progressive of the disease is it's slower for women, no, faster for women than for men. But this was a great conversation. I can't wait for next Sunday when we're going to talk about OCD in teenagers. It's going to be very, very heavy. Probably we'll talk more about the clinical part than the neuroscience part, but I look forward to it, and thank you so much for joining us.
Thank you, Lee. To me, it's a very good pleasure doing this video every Sunday with you and the Ibarra Exchange, and continue working hard. Take care. See you next Sunday. Bye-bye.
Until then, have a good day.